So, any introductions that you want to make?
Yeah, I have, I'm bringing a new hero here to introduce to the board, Deanna Cardona. She just joined our team on Tuesday. And she's going to be working with the children with the medical handicap program. Uh, So Deanna, do you want to introduce yourself to the board real quick?
Sure. So I've been a nurse for 9 years, Deanna Cardona. Just have some peds experience, have some home health experience, and I'm excited to work with everyone. This is like by far the friendliest, most wonderful environment I've ever worked in. So it's been a great first week.
It's early.
It is early.
You're probably new.
Thank you.
And on your first week, you got to meet the board too, so.
Yeah, all in 1 week. Yeah.
A short week at that.
Yeah.
That is all.
Thank you, and thank you, Chad.
Oh,
Okay, so approval of today's agenda items. We're looking now for approval of today's agenda items. Are there any corrections or changes to the agenda?
No corrections?
Okay, can we get a motion to approve?
So move.
A second?
second.
Okay, all in favor, say aye.
Aye.
Thank you. And then the approval of December 16th meeting minutes. Are there any corrections or changes to those?
No correction or changes. I did include them in the packet and unless anybody else have any questions or concerns with what came in the minutes. Was pretty much verbatim
Okay,
what happened last meeting, so.
motion to approve?
So moved.
Second?
Second.
Okay, all in favor, say aye.
Aye.
Okay, next, the bill schedule.
If,
You want to walk through it?
sure, real quick, our bill schedule for December was pretty light, which is just one pager. Usually that's pretty typical what we pay bills in December just to finish the year. So nothing out of the ordinary. That's pretty much the bills we pay every December, every month.
Okay, can we have a motion to approve the bill schedule?
So moved.
A second?
Second.
Second.
And all in favor, say aye.
Aye.
Okay, a Board of Health to approve and adopt the 23-25 Community Health Improvement Plan.
All right. This is, we gave you last meeting, we did discuss kind of in details, some of the initiatives that came into that plan. This is the plan that been in the works for the last 4 months here with our partners, at the hospital, at the Adams Board, the foundation, the United Way, a whole coalition that's been working on that, the whole community. So I think we are getting ready to kind of publish the report to the public and release it. And before we do that, we want to bring it up to the board to kind of adopt it. The release, we're planning on releasing it on the 31st. Today, right after this meeting, I have a meeting with Dr. Coase and Adams to kind of figure out how we want to do the release. Do we want to do an event for, press event, public event, or we want to release it in just a press release and kind of keep moving. It's really good plan for the next 3 years. We did talk a lot about the initiatives that public health is responsible for. In partnership with the hospital, is the diabetes, the hospital and Adams Board on the opiate epidemic. We do have an initiative on smoking and vaping in schools. So it's pretty well-rounded plan, and we're hoping that we can, in 3 years, we'll work on those initiatives. We'll come back and report to the board as we go and report to the community as well. I did mention that Jessica Shrake, our epidemiologist that's on contract from the CDC Foundation, is working on a dashboard. So that dashboard, I think it's going to help not only us, but the community understand the progress on that plan, which is a bit different of what we've done in previous cycles, but I think we always wanted to shorten up our reporting back to the community and the progress we're making. I think we're pretty positive. I think we're all excited about this plan. Dr. Coase, do you want to add anything to?
No, I think that's a high level. If anyone has any questions, I think that was sent out pages 37 through 30 or through 47 or something like that are the specific plans got individuals that have volunteered to be part of that. We're in the process of trying to figure out the organization as we drew up last time, but I think we've identified those and we're going to come up with a oversight committee that will be looking at those on some type of a, let's say, a quarterly basis. And then, as Kareem said, the report back will be back to here, to the other groups that are involved, as well as to the community. So I'm pretty excited about it. Had a lot of interest. As just a couple of examples. Well, last week we were out here with a couple of the directors from the hospital talking about things we can do with kids. I had somebody stop me in the hospital yesterday and said that she had talked to the individual that she goes to a gym, that there was a group there, all the, I'll just say private gyms that would really like to be involved in what we're going to do with exercise, obesity. And I talked to a couple pediatricians earlier this week that are really interested in doing something with this, the pre-diabetic, with the obesity issue and things like that. So we need to, we'll come up with some plans and I think there's some excitement and there's broad community support. So glad to answer any questions. And if any one of you are interested in volunteering on things, and I say that if you have some real interest of things, I think that people, but I really do think the more individuals we get involved, and I think, Bill, you made, or someone asked last month about the faith-based community. We're going to be working with them too. Laura will be talking a little bit, not so much about the faith-based, but about these community health needs, these workers that we need to be able to guide a lot of individuals out there in our society. So anyhow,
Yeah.
anybody have any questions?
I will get the board more involved as we go, as we are reporting back on the different initiatives, some of the challenges we're having with them, and we might ask for your support as we go, on enacting different things to make it happen. So it's a very, very flexible plan. I think the bottom line is we want to see progress in the next survey in 3 years, and hopefully we will.
I guess the one thing I thought of reading it over, it is very detailed. I congratulate whoever went into the detail. Is getting the people who are at risk involved.
Yeah.
The smokers, the vapors, the drug abusers, the users. It's a tough group out there. I mean, they're doing it for a reason, or maybe they don't know the reason.
No, that's it.
And just, you can identify them maybe.
I think this is the way I would answer. I think it's a really good question. And that's what Laura and I have been talking about, is people that, let's just say, have all kinds of problems. I think we've learned a lot with the ROSC and the addiction of, you do need support. You need someone. It doesn't have to be necessarily a healthcare person, but if you've got someone that you can talk to, ROSC is the recovery oriented, the opioid kind of thing. And I think the data would say that, Mike, that kind of thing helps, but we do need to get a lot of support for those people if they get into the system, so that there's some way. I use the word navigated. I don't know whether that's the right term or not, but there are, and Laura can give you all kinds of examples of individuals that she's seeing from the mobile health of that kind of thing, of whether it's educational, whether it's choice, whether it's whatever, is that they need an awful lot of help. So one of the things that, just talking about vaping, is, okay, how are we going to identify these people? And then when we identify them, what's going to be the plan? Because it doesn't do any good to just identify. I mean, that's your point. Okay, so we've got, and I'm making up, well, I'm not going to make up a number. I don't know how many kids vape, but apparently it's all over the place. So what are we going to do, and how do we go about educating and trying to get some outcomes? That's the biggest thing on the scorecard. Is it's okay, we've got to make a difference when we do things. So
This is definitely a good head start. I mean, just to identify, here are community problems, here who needs to be involved, who is involved. And
yeah, I mean, just that as an example. I don't want to, our CME today for the hospital it is about, specifically about physician burnout, but I was talking to their director, who's an addictions person, and he was making the point, which is what we've tried to do in the community, specifically about that, if you can wait till you're 25 and you don't start using whatever it is, smoking, opioids, or what, that you're less likely to get addicted. Still may be illegal, it may not be good for you and all that, but it's that brain, especially in males, the brain between 16 and 25. So trying to approach it scientifically, that's just education. But if you get peer support of your friends that not, again, I don't thank goodness I don't have any kids in school anymore, that I don't know what's going on. And so how do you get enough, let's say, peer pressure, things working through? So those are just my thoughts. We got some experts here on that kind of stuff, but it is really tough.
In public health, it's progress it's really hard to see immediately. I mean, we've been working on the smoking issue for 50 years. So changing behavior is not easy. And I think that, like you mentioned, Dr. Lindenwood, this is a good start. This is something that, universally, we need to target that issue because the survey showed that we might have an issue there. But nonetheless, we do have a lot of resources in town. And what's really exciting about this plan is the plan of having like a community navigator. Not assigned to the hospital, not to public health, not to mental health, but more of a community-based where that person will connect all the navigators together and get the people who need help as soon as we can, as soon as they are identified. So we're hoping that we can make a little difference quicker that way, because just identifying people, identifying them in a survey, do programming, but if they're not benefiting from that programming, it's not going to do us any good, or progress is going to be really slow. So going back to how we make a difference, I think we go back to the basic public health principle, go to the root cause. What's causing, all that? What's causing the kids to vape? Just the sooner the better. The sooner we can get to that population, the better we are.
When vaping came out, it was marketed as great.
Yeah.
And that's
It's an easy way to avoid smoking. It's good for you. It's easy. It's socially accepted. I mean, every positive thing out there.
Mm-hmm.
And then how do you counteract that once you,
Yeah, I know.
you can obviously, but you're
It's
starting
money
from
and
behind.
politics as well. I mean, those are all factors that will factor into changing behaviors. But again, unless we're gonna have to keep trying and try hard.
Mhm.
Yeah, kind of as an aside, so this, I'll use up my time, but what you're talking about, this thing with diabetes we talked about last time is really unbelievably exciting. Because it's behavioral modification that people are seeing themselves that I can do that. And we were talking to them this week. I'm trying to figure out some way I could do one of these that would be carbon monoxide levels. So if you smoke and carbon monoxide, people get that when they see that kind of, well, at least if you can extrapolate from what has been done with blood sugars, that they're all talking about it. And these are not people that have got their PhDs. That, we took anybody that, well, Laura can talk about that, but it's really interesting. Back to the point of what Kareem, the root cause, if people really don't understand, or most of us think, well, you're going to live forever, I'll put this off, I'll make changes later, or I'll exercise, all that kind of stuff. But this is instantaneous feedback, which really seems, well, at least in the diabetic, I cannot believe the results that have got from just putting this thing on and letting people look at their blood sugars. Yeah. You need a vote, right?
I need a vote to kind of approve and
One
adopt the
question.
plan. Sure.
I know the last meeting you kind of talked about who would take the lead coordinating this.
Yeah.
So what's happening?
Well, we've got a plan for a group. In fact, I've got it here, and that's what Kareem and I are going to talk about, of who's going to be on the check marks in addition to the Adamus Board, Public Health, and us, and the Community Foundation United Way. We talked to Kathy Fell, and they want to be involved. So there's probably going to be a group, Bill, of about 9 that will be looking at all of the reports that come back from whoever gets assigned to this. I'm calling them task forces. I don't know what they'll be. Like, for example, I think that tobacco, vaping, public health, that will probably end up meeting together. And then we'll have, okay, this is what, and here's So what we need to do is establish in the task force is who's responsible for it to start with. The person or whatever, and then what's our goals and what's our metrics? And that's, I think, really important what Kareem said. We got a scorecard. If we say on vaping, we're going to identify by this, okay, did we get that done? That will report back up to that oversight committee, and then that's where the reports will come out of. So I think we've got a structure that everybody is pretty much agreed on that we're going to try.
Well, yeah, I just, what you're doing is quite comprehensive, and as long as it gets coordinated, I think
Yeah.
that's all you can hope for.
Yeah, anybody can have a plan. It's the execution of the plan. About 20% of the time, I think that's the Peter Drucker quote. So your point, but that's where feedback is good. I mean, okay, are we on the right things and what?
So do we have a motion to approve the plan?
So moved.
A second? Second. All in favor, say aye.
If I can amend that motion to say approve and adopt, so we can go ahead and start working on it. So.
Okay, approved.
All right.
And then the next item is the health equities report.
Sure. That's kind of the second report that goes really hand in hand with the CHIP. I did put a little fact sheet together for you really quick. This is like a 65-page report. A lot of really important stuff in it. But in a nutshell, this is kind of for the first time on the county level, we're examining the health equity and disparities in our county. And sure enough, we did found a lot of the disparities going on. I think this is going to be a great resource for all the groups and work groups and coalitions that are working on the CHIP. And going, circling back to Dr. Linda Mood's point, this is going to identifying what the needs are and when we need to target a lot of the resources. So this report was done by, again, two of our best epidemiologists here, right after Chad, Jessica Shrake and Hannah Plumley. They did really good compilation of the data. It talks about different aspects, but basically it talks about the social determinants that we are trying to tackle here to get better health outcomes. At the community level, you're going to have to look at housing. You're going to have to look at transportation. You're going to have to look at food security. You're going to have to look at education. All those will come together to make better health, better healthy outcomes for our citizens. And I think as Board of Health and as public health and the hospital system as partners, we ought to look beyond the walls of the campus of the hospital, beyond the wall of the campus we have here, and just go out in the community and make sure they're all engaged in changing behaviors, in making good decisions, healthy behaviors, all that stuff. There's an overview here on this page. It talks a little bit about poverty line, and it's really cross-cutting in every data set we look at. Poverty is really a problem. Whenever you see people making less than $25,000 a year, you see really poor health outcomes. So poverty is a kind of underlying factor on all this. Housing, to income. We looked at high school graduation rate and education and how this is affecting health in Hancock County. We looked at food assistance program and what percentage of our residents are participating. That will give us an idea about food security and how people are affording stuff. Then we did a mortality rate kind of study, and this came really with not surprising results, but you can see it in print now, that if you live in one of the high census tracts or census tracts identified as having disparities, you are more likely to die earlier than your peers across the street or across town. And I think
Now, does that refer only to Hancock County?
only Hancock County, this is purely local. This is going to be a great tool for when we go to our elected officials, when we go to city council, to just tell them, you know what, you're representing census tract 9.01, census tract 9.02. Those are two of the top census tracts that are scoring poorly health-wise. What can we do about it? How can we work together to make it happen for your residents, for your constituents there? So this is it's a compelling story that we can tell in real numbers, real life of what's going on. One of the top 5 disparities noted in the report, where the percent of residents living below the poverty line, percent of residents spending more than 30% on housing, high school graduation rate. So a big disparity between people who graduated high school and people who did not.
Now, does 1 and 2, or does 2 tie into 1?
They're all tied up together kind of, but even if you are working and above the poverty line, we do have a disparity of how percentage of our population are paying more than third of their income on housing. Housing is expensive here, we all know, and there's a shortage and everything else. So this is going to help us working with the Housing Coalition to make sure we can tackle some of those inequities, because it's affecting health. This is, that's what the data proved. So on and so forth. But again, this is gonna be striking when people will see in numbers that people are in that census tracts are dying a lot earlier than others because of many social determinants that are not taken care of or not addressed at the community level.
For example, number 4, residents participating in food assistance. And number 1, which shows over a third of people living below the poverty level, federal poverty line. Does that mean that there should be more people participating in the food assistance program?
Well, that's the problem. You have to apply for that.
Yeah. And that's when the navigator, the community navigator we talked about might come and play. We talked in previous meetings about Laura and our medical staff doing a lot of the social work when, with our clients, people needing assistance with transportation, with housing, with shelter. They are doing all that work. I think the community will be served better by experts just focusing on helping people getting the resources they need that are in the community, and then help them graduate, from that and get better, better jobs. Everything is kind of connected. That's why you're going to have to work on it all together, with the community partners. If we keep sitting here month after month and talk about the issues and kind of do programming just here for us, I don't think we're going to make big progress. We have to be out. We have to be talking to our partners now that COVID is not the distraction anymore. I think we can do a lot more of that.
So Bill, just, again, we got a lot of experts, how you do community health and what you do. So you were asking what would we do with our task force. First thing I'd have them do is read that report. That's really a good report, because I don't think people realize that about what's going on. So if 9.0 is where we got problems, that's where you go have a forum, rather than asking them to come to the hospital at Marathon or something. Go find where they are. You hear that, the opioid, you got to meet them where they are, and that's geography. So maybe having and asking people to come in, there may be, they don't know or whatever, that's who we do need to connect with some food. And that's the thought process as we go through this, I think, on a lot of these different things.
And that's probably where the mobile health clinic is a real asset.
Exactly. Yes, exactly. Especially if we find out. So again, if you had a forum and you sit around with 10 families and we can afford to go to see physicians, or gee, we didn't know that you could go to the mobile, whatever. I don't know how much of it's education. People are overwhelmed because when you look at, again, the stating the obvious, people aren't making a lot of money. A lot of them are trying to work 3 jobs. I mean, they don't have time to be going to me. They're just trying to survive. And so, gee, we didn't know there were those kind of resources. Again, these people are dealing with this all day. And Laura, she'll give her a report.
So part of that report, I did ask staff to kind of look at, okay, we identified health disparities. How do we what kind of action or examples of actions? And those are not really the whole, very comprehensive. Those are kind of, we brainstorm a little bit of how do we use their report to, again, make a difference and do progress on community health. We want to use it to increase community awareness. A lot of people don't know what's going on, on the street level. Um, we have to have strategy that's universal enough to, okay, well, immunization for everybody, but how do we target that population that's scoring low? So we have to have kind of a dual strategy now and of universal targeting, universal the whole population because we serve all of them, but target intervention to where it's needed most. Same goes with allocating the resources in proportion to the needs identified. Utilize the mobile health clinic to provide healthcare access to underserved areas and so on and so forth. Um, Unemployment and uninsured rates are correlated. That's why a community health worker or navigator working with job and family services, working with other services here in town, can help people get, low cost IDs, birth certificates, all that stuff that's needed to get a job and be able to be productive. We want to continue to work with local farmers on accepting, food stamps or SNAP benefits as payments. This way, people will go spend them on healthy food. And work with the food bank. This is going to be big, and I think we started working on some of that initiative as well. We want to work with the food bank to provide prescription food distribution boxes, for diabetics, for people with high blood pressure, so on and so forth. Special food distribution. Again, working with everybody. Community gardens where there's no supermarkets, no grocery stores in some of the areas we identified. But at the very end of that report, there's a lot, because we talked about the census tracts, the maps are really powerful tools to kind of see exactly where the issues are, where the resources are needed. So those are the different census tracts, overlapping a map, street map, just so people can orient themselves of where we at when we talk about census tract.
Did every county in the state do one of these?
No, there's one, actually,
What, this is
state
very
did one.
comprehensive.
Yeah, this is a really in-depth study. I know the limitation is it's a couple years old, but nonetheless, a lot of that same data is still valid. Because we're always behind on getting the data on different things, smoking, graduation rates, all that takes time to report back on. But this is really valuable. I did present it to the delegation a couple days ago as a draft, and then everybody is excited about getting copy, keeping it on their desk, and everything they need to do, they need to look, okay, is that a need? Same with funding agencies. A lot of the nonprofits depend on the foundation, depends on United Way. Now, as they are applying for money, both ends, the funders and the people asking for the money, they can go and say, okay, 9.01 needs help with, with food. It's a food desert there. If you are proposing that, we'll go ahead and fund it. So this is gonna come full circle probably in a couple years, but nonetheless, this is really valuable data. And I think this is gonna be kind of, the Bible for all
Right.
social servants here and public servants in Hancock County, just again. Even elected officials probably should keep it handy.
Well, everybody wants to see data.
Yeah.
This is data driven, this is real stuff.
So again, this is a lengthy report. We're gonna print some once it's adopted by the board today. We're gonna do some in prints, and I'll make sure you guys have copies of both this and the chip as well, hard copies. This way it will be easier to follow and easier to kind of.
Approximately, if you know, how many other counties did anything like this?
You know what? I know the state do an equity report. They do it, I think, every 5 years. The CDC, they do their health equity report for the whole United States every 10 years. So the last one done with the CDC was in 2013.
So it's really difficult with the lack of everybody doing it to say where
Yeah,
Hancock County stands.
That's correct. Well, they do in general and the context of the whole state and the whole country. But this is going to the street level and saying again, you will live longer if you are in across town from a census tract that's really scoring for. This is powerful stuff, powerful data, like Dr. Coe said.
And it'll be a learning process.
Yeah.
You know, as we
So,
go back and,
so,
We have to point to.
exactly. Especially back to faith-based community or things that, doing things in the community or wherever we can put resources and things, I think it will attach.
so we do need a motion to approve and adopt the health
Please.
police report.
So moved.
Second,
Second.
all in favor, say aye.
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 Thank you. This will be released next Tuesday. Again, I don't want to release both report in 1 week. I don't want one to kind of, you know, skirt the publicity that the other is gonna have, but we're planning a couple things with Cheryl and the media too around the release of that report as well. So very good. Thank you.
Okay, next is the first reading for the proposed 2023 for CPR training.
Yes, and if you remember last year, I did come to the board in June, asking that there's a need for CPR training to be done here in town. And public health is gonna step up and kind of get a few of our employees certified in that training, and we did. And back then, I did bring in some idea of what we want to charge for those. The initial launch of that certification class was to get people to participate. I mean, public health, we're not in the business of making money. We're in the business of giving the people the tools to save lives, that's the bottom line there. So we did kind of a reevaluation 6 months later in December, and I did sit down with the staff who were doing the classes. We did sit down with fiscal, see how we're doing on those. They're very good demand for those classes. A lot of agencies, a lot of people wanted to be certified, especially we're kind of the only game in town right now too, to that respect. So we did a little cost analysis, how much it's costing us to kind of provide the class. And it turned out that we need to tweak those fees that the board approved back in June. That's the projected cost in that first column. The BLS, which is the basic life support class, that's costing us $106 with 2.5 hours of staff time. Then we took the salary with fringes and we divided to come up with an hourly rate. So bottom line, it cost us $106. Currently, and in June, the board approved the $75 fee. So what I'm proposing today is for the board to approve a $100 fee moving forward for 2023, so we can recoup some of that staff time we're putting on there. Recertification, it's costing our program $37.50 with the books and everything else. I'm proposing to be on par with what other places are charging for those classes. And recertification, I'm proposing a $50 recertification fee, just to make it easy. For the Heart Saver, it's costing us $107. We were charging $40 for it. And I'm proposing to bring it up to 100, again, to be on par with what the market value of those classes are. Recertification, same thing in here, just want to make it easy, I make it $50. We were charging 25, and 54 is our cost. Now, there's a requirement with the Department of Education for high school students to go through CPR classes before they graduate. So we are, again, this is something we want to provide as a public health service. And we want to keep the cost. It's costing us $5 to get them the card and the material. So we're keeping it at $5, and we're kind of donating the time as a public service time. For only if you are connected to a school setting where we do training in schools.
So is that last thing directed more at the high school level?
At the
or
high school, it is
not-
high school.
Not kindergarten.
No, but we call them K through 12.
Senior year.
Yeah.
They have to have 5 years.
Yeah.
So a lot of them do it.
High
their
school.
Junior years.
So I'm asking the board today to kind of, again, based on that principle of, pay for service or kind of with the licensing and everything else, to recoup some of our cost back while keeping the public health value and service to that CPR class. I'm asking the board that we to approve the first reading of those fees. By our bylaws calls for three readings before we install a fee. So I'm gonna need two motions back to back, one to approve the first reading, and another one to approve the fees on an emergency measure. So we can go ahead and start charging whoever's booking those classes moving forward.
So Kareem, are there any grant dollars available that can help with this?
We did tap into a grant last year from the foundation. They did help us with buying equipments like mannequins and AEDs for show and everything else. There was a couple $1,000s. Now, like any other fee, if we feel like there's a hardship to any person that will need that certification but cannot pay for it, most of it agency will pay for it. Like people will come from a whole. Some of the agencies we trained is with the Habitat for Humanity, just an example. They will pay for certification for their staff, so on and so forth. So it's mostly corporate paying for those. But if we feel there's a hardship, we'll bring it back to the board and the board can make an exception and waive the fee
And it's $100 per person?
per person.
I mean, I would worry that that is cost prohibitive for some people that might individually want to come and do this. Is there any opportunity, even with these fees in place, to do any type of an event where you, like a Heart Saver event where you open it up to the community for free and
Well, I think we are planning an event, but for certification purposes, you have to have 6 per instructor at the most. So you cannot have more than 6 people per instructor. So to get the actual certification and the actual card and go through the whole class, there's some, again, the book on that BLS course is $17.50. The book on the Heart Saver is $20, and $20 for the card. So in that cost, there's the cost of getting the card, getting the books, and paying our fees to the American Heart Association as well.
does everybody have to have their own book?
Uh, Pretty much, they have to have it as a reference, I think.
Through American
they do.
Heart Association. So you can be trained, but you can't be certified, I don't believe, without through the American Heart Association if you don't have the material.
So what percentage does the Heart Association get?
They do get the price of the book, and they do get the price of the card. Our investment is staff time in each and every certification. Circling back to your idea, I think this is a great idea, and we thought about that, and we were thinking of, I talked to staff about doing some in February, since it's Heart Month, where we go to the mall and do compression only training for everybody. It's open to the public. We want to give the tools to everybody to be able to save lives. It's just a matter of, I'm in a dilemma now. Do we recoup some of that staff time that they're putting into those, their communication with the American Heart Association to get the books, to get the cards. Most of the people who needs the actual certification, paper, there are people connected to agencies. I don't think, a few people want it. And if it's connected to schools, it's still $5 just to pay for the card. So, and again, I did task him with seeing what's going on in our area and how much people are charging, how much other agencies, other opportunities for those classes are charging. The lowest came at $125.
I think it is needed. I'm really happy you're doing it. I'm just trying to figure out how people that don't have that kind of money to spend, I think that would stop, individuals
Sure, and I think you brought up a good point as well. We can look into scholarships instead of coming back to the board. If somebody can show hardship, we can have scholarships maybe through the foundation or some. Put $1,000 on the side and say, okay, those are scholarships for CPR, people who cannot afford it, or it's prohibiting them from getting the certification.
I think BJ raises a couple good points, because I had the same question, will this drive people off? And she, is this something that could be taken to the community foundation and say, hey, help us out?
Absolutely. But I think for, again, as agencies and entities are calling to schedule those classes, we want to be able to have kind of a price structure.
Mhm.
But any,
Well, that's fine.
any deviation from that, probably we can deal with it, whether with a grant or coming back to the board and say, you know what, such and such a, ask for waiver, and we can grant waivers that way.
All right, we need a motion to first approve approve the first reading.
So
Second.
All in favor, say aye.
Aye.
And then we need a motion to adopt the proposed CPR training certification fees.
So move.
Second,
Second.
all in favor, say aye.
Aye.
I'm gonna do a roll call on that second one.
Okay.
BJ,
Yes,
Nancy,
Yes.
Bill,
Yes.
and Dr. Linda Moon.
Yes.
Very good. Thank you. All right.
On that
Yeah.
same topic, I think this would be eventually a good PR thing to put in the paper, because, costs have gone up. And you've, alluded to checking with other things other districts that have increased their fees. I just think our citizens would be, like to know that.
Yeah, and we will still offer the free just compression. You don't need a card. You don't need kind of actual certification. Those are quick things that you can learn to save lives. I think we
Sure.
want everybody to have those tools. When we go out on, and festivals and fairs and everything else, we can do classes like this, but we want to plan one for February where we invite the community to come and learn quick CPR here, just compressions, to be able to save lives. I mean, the bottom line is we want people to have those tools. It's just a matter, again, we want to balance, can we pay for it long-term? Can we sustain it, with staff time or not?
staff reports.
All right, we're gonna start with the financials here. We closed the books on 2022. I think it was a good year, just to keep in trend with the 7 years we've had since we started. In 2022, in all, we did bring in $3,899,270.68. And we spend a little less than that. So I think it's always good to spend less than what we're bringing in a year. And we ended the year sitting up on $1,581,984.37 in cash. That cash compared to where we started the year, it's a little less. And the good question would be, we bring in more money, but we ended up with less cash. This cash is reflective to what we have after we encumbered the bills. So fiscal year, it's not a clear cut, we don't pay all December bills in December, we don't pay all January bills in January. There's overlap, and that's where that few $1,000s difference in the cash. So a lot of the cash is minus the encumbered money that we did back in December to pay January bills first thing in January. So if we look at the flip page where we did a little comparison as well, this is pretty much looks a lot like 2021 as far as revenues, and same with expenses. So I think we're trending a little higher when we started back in 2016. And our budget grew from 2.5 million to almost $4 million. And in 5 short years. Most of that, again, it was in addition to additional burden to our municipalities and townships we serve. It was more of leveraging grant money and bringing in money to increase services in Hancock County. So I think you all and the staff deserve kudos on what we've done the last 7 years. Really, it's really impressive. I've never seen that growth really that quick. Any questions about 2022 finances?
Oh, great job.
All right. So, Dr. Coase?
I think really I've covered most of mine with what we talked about with those 2 reports. Kareem did pass out the flu report, influenza-like. We are at the hospital, BJ, if you want to add anything on, we're seeing COVID as we've seen before. We've been busy, a lot of respiratory infections, some influenza, just all kinds of respiratory, but not really any change the last month. And we haven't seen any cases of monkeypox. I just want to that, so that seems to have died down. I thought there might be a couple things as I'm just reading you might be interested in. I'm going to be leaving here pretty soon because we have one of our medical opioid task forces, but and I had already talked about the pediatricians that there was something this week that came out. Fentanyl, the group that is increasing the fastest with overdoses and things like that is the age group of 13, 14, 15, something like that. Now that's a percentage increase, but still we're just seeing it younger people. And the other thing is, it's just interesting. I'm going to make a real high.
Does that indicate that there's a market?
Yeah, I think things being used, and I don't think it's going through vaping, although there's all kinds of stuff that are getting added. I don't know, does anybody know, are they adding fentanyl now to vaping? But there's all kinds of stuff, especially with cannabis, about what's going on.
That's what I've heard a lot, reports of people getting that through marijuana use.
Yeah, and that's the last thing. This is a high level. It's just interesting talking to my friends how many people are trying cannabis. And when I say that, because all of us are getting that, and that's the old people, and I get whatever problem I got, rheumatological, Parkinson's, everybody is saying, well, why don't you try this? So anybody goes to Las Vegas, they go to California, they go to Colorado, they go anywhere. The dispensaries are everywhere, and people are trying gummy bears and whatever. Okay, now, besides that, I just want to let you know, if you're going to have surgery, you want to let the anesthesiologist know, because they have shown that if you've, what was interesting, especially if you've just used within 2 hours of having surgery, which I thought, now that would really be crazy. You're supposed to be NPO. But then I thought, well, if you're really anxious and you're using cannabis for your anxiety, you're going to have surgery, you probably would chew a gummy bear. So let them know, because there's a higher incidence of heart attacks, respiratory problems, and things like that. You probably didn't see this, BJ, but the American Academy of Anesthesia, and BJ is responsible for surgery at our hospital, have put out this dictum that should be a screening question we ask right before you go to surgery. So that's all I've got. Anybody have
So
anything?
you're gonna request more gummy bears then?
Yeah. Oh, I did. Bill sent out something, and Mike responded really well about Pavlovid, about treatment. This has been a tough one. We talked about it, your point, but just not everybody agrees with treating. I mean, that's a problem, maybe. There's some different kinds of opinions. And then the interaction, because it does have interactions. There are a lot of people of taste and people that I have talked to that are taking it, that if nausea is not too bad, go ahead and take it. It's still worthwhile, but there are side effects to it. We had a department meeting the other night of primary care, internal medicine, the family docs, and Nate went over all of those kind of things. So hopefully we have educated us. Good question. I thought Mike responded to it really well.
Mhm.
That's all I got, Kareem.
Good. Just want to add to Dr. Kosa's report on the flu. I think we're in a good place right now. We're almost mid-season, so it will be kind of interesting to wait and see what's going to happen in February here and early March before the season peaks and start subsiding for the year. But it's looking really good in our area as well, which is really positive and encouraging. We had our share earlier in the season, but we're hoping that this is the only peak we've had or will have this season, and we'll see what comes in the future. Same with COVID. COVID is on the low end where infections are decreasing, and we're at low transmission right now.
It's just interesting on the COVID. Talked to somebody last night that there's no question it's going down, that people are not as sick and whatever, but there's still individuals have been vaccinated, whether it's the latest variant of terrible headaches, really sick, almost influenza-like symptoms. So it's I don't know if interesting is a word, but we're still seeing some bad cases of what people have related to COVID. So the difference between what one person has and another is really it can be very significant.
Is it possible to differentiate between COVID and the flu?
Yes, we have a routine test that we can do. We can do RSV, influenza, COVID. The problem somewhat, I don't know, it's a problem, it's expensive. And so is it worth, charging you to say, well, you got this, but you still got a virus. So this is what we're going to do. Now, if you rule out COVID, because I think anyone over 65 in general, or if you're immune suppressed, should be put on Pavlovit. That's standard, and that's what everyone is saying. Influenza, well, I think you'd want to go on Tamiflu. So I think it's worth it. But, for a lot of people, again, we're back to if you got a $5,000 deductible, you don't have any insurance until you spent $5,000. So if you get a bill for $500 for a test or whatever the test is, I mean, we have to deal with this all the time with what we do. You have to kind of balance that, but there are tests that will differentiate those.
So if you see somebody on Medicare, then what?
Bill, we'd do anything you want. You would be covered, and yeah, the thing about Medicare is that they set the price. So, yeah. And I would say, BG, I don't know if you want to comment from the ER. I think in general, we're trying to test, because if you're in the emergency room and you're sick, I mean, and most people that come to the emergency room, they don't come there for a holiday. They're pretty sick, that we try to differentiate what's going on so we can sort out. The big concern as doctors, Mike, is we want to make sure you don't have something bacterial. You don't want to send somebody home with COVID and they got pneumococcal pneumonia, because you may not do too well, and we can treat that. So we're maybe a little more, I don't want to say aggressive, but we're going to be doing that kind of testing, chest x-rays and things like that.
Good. Just circle back. There was an interesting email chain that went out earlier in the week that Bill started, and then Dr. Lindemood just added to it about Paxlovid.
Yeah.
I don't know if you were on that. On that email.
That's what I was talking about.
Sure.
Yeah.
Very good.
Yeah, and Mike was pretty accurate too. I
Yeah,
thought he did a
yeah,
pretty
it
good
was
job.
on the money.
Blind squirrel will find acorn.
Very good.
I thought his response was a little wishy-washy.
I didn't want to call you out.
Very good. All right, Laura, you're next.
All right. So on my report, I wanted to kind of summarize what the mobile clinic did this year. So over here in all these tables is kind of the approximate hour information we've given out, and kind of at a big look back stance on kind of what we were doing. And when I'm talking about hours over here, that's accounting the mobile clinic, how many hours it was out. So usually when the mobile clinic's out, it's myself and my medical assistant or more staff coming out too. So I didn't multiply it by 2 or 3, depending on the staff. It was really just how much the mobile clinic was out. So that's what we really were doing, throughout the year. And, I came on full time in September and did some part-time work, over the summer. So that's what we were doing. And then all the educational things we have done. And then this also includes physical examinations that I've done, vital signs, point of care testing. That's what POC means. And then we also did like some vaccination clinics. So how many COVID vaccines we have given out to patients and influenza vaccines. And this over here, continuity of care, this is more kind of in referral to City Mission, like what we were doing over there, and also Hope House. So you can see up at the top, I prevented 9 unnecessary ED visits. And this is my account of, okay, I saw a patient at the City Mission. They said, if you weren't here, I was going to go out to the ER. Like that's how I kind of quantified those. And the same as these urgent care visits. If you weren't here, I was going to go, here or there. And then I did have to refer 3 people over the course of this year to the ED for things that I just couldn't take care of. I thought somebody had a clot, like those types of things. I referred a couple people or one person to urgent care just for STI testing, just because I couldn't do it at the mobile clinic at the time. Refilled some medications when patients were out, and those referrals to mental health, about 15 other specialist referrals. I've seen a lot of patients who should have followed up with cardiology. I had open heart surgery 2 years ago. I've never been to a cardiologist or open heart surgeon after I, had this, surgery done. So a lot of those specialist referrals were to cardiothoracics, vascular, cardiology, and pulmonary were the main ones, and neurology, a couple ones. And then PCP referrals, either getting those patients over to Kaufman Clinic that aren't established with the PCP or over to Terra Nova. And that's primarily City Mission with a couple of Hope House clients. So going down farther, there's kind of looking forward to 2023. So I really kind of hit big and kind of a description about what we're going to do with the STI and reproductive clinic. So turned in all the grant information that I needed to. So hopefully, fingers crossed, we're going to get some grant funding for this, which will allow the grant will pay for patients who can't afford birth control, who can't afford pap smears, can't afford to come in, to the clinic. It'll pay for those patients. And so that was a little bit of description about what the reproductive clinic was going to do. Other things that we're doing is, of course, we're doing the Dexcom study project still, and I have more description on that. Weekly City Mission outreach, still going to do that. Involvement in the CHIP, that's kind of to be determined depending on these task force. I plan to be really involved in these task force to see how the mobile clinic can help, especially in that census track of 9.01, 9.02, to see where I can actually deploy the mobile clinic to help out with those in need census tracts. I actually took the mobile out the other day and drove around the census tracts, and a lot of that 9.01, there is a big mobile park areas. So I think that would be a great area where I could take the mobile clinic out, publicize that I'm going to be here. We're going to do X, Y, and Z today, to really capture those census tracts to make sure we're, helping them out. And then I continue to plan on doing some community wellness events. Like last year, we did the Marion Township Wellness event. I plan to go out to different townships and kind of do those things as well. And also like the faith-based community and vaccination clinics. We're going to plan on doing those as well with the mobile clinic this next year too. So those are all kind of to be announced date wise, but I want to kind of make sure it's all kind of evenly distributed throughout the year. So we have good coverage.
Exciting year.
What'd you say?
It's gonna be an exciting year.
Yes, exactly. Yep. So yeah, I'm really excited for the next year. And then, like I said before about the Dexcom study, we have kind of made a plan with Dexcom of what we're going to be doing with their company going forward. So Dexcom is investing into the first 300 patients. So right now we're at 266. I think over the next week, we're going to be able to hit that 300 mark. We're going to take a break. We're still going to be getting referrals. So I still encourage all those primary care providers, specialists to send in the referrals. They're just not going to get on Dexcom until we go through the next wave of, clients. So with that first 300, Dexcom is committed to doing those and then getting started. Hopefully we'll have another 200 starting in summertime. So that's their commitment, is they're thinking about 500. And then also this is kind of intertwined with the CHIP. So once we get these task force kind of going and things, we'll see how the CHIP involvement's gonna work out with the Dexcom project as well. But we're seeing great results. So now we've had more patients come back for their 6-month follow-up. So we have 28 patients who have came back for their 6-month follow-up. 151 patients have came back for their 3-month follow-up. So an average A1C decrease of 2.2 for their 3-month follow-up and an average decrease on the 6-month follow-up of 2.7, which is very significant. We've had some great weight loss reports too. Specifically on the 6-month, we had a client who came in and she's in her 40s and she started a new medication. Her A1C was like 11 when she started this project. Now it's down to like almost 6 and she's lost over 30 pounds. Just fabulous.
Is she trying to get on a commercial?
I know, right?
Well,
I feel like I have-
Dexcom is looking for those kind of people.
Yeah.
It was really an interesting talk with them.
You know, and also I hit on that kind of narrative on the Dexcom study where it's kind of going also. We had a doctor who graduated from Harvard. He's working through the Diabetic Association, Behavioral Association in San Diego, working with the University of California to do a behavioral study on this. So he's got it at his IRB at the University of California, but what he hopes to do is interview 2 kind of cohorts. So the first cohort would be, let me do a 1-hour interview with these patients who are having these types of results after 3 months. And then the second cohort of interviews that he wants to do is more kind of questionnaire based. So hit them before they even start and then hit them at 3 months and so on and so forth to see, you know, those behavioral modifications, like what in their behavior has really changed and how does real-time reporting really go into your behaviors. And then also Dexcom was talking about potentially, okay, Dexcom, this continuous glucose monitoring system is not supposed to be lifelong, you know, for certain patients. So potentially, you know, okay, you got a great A1C, let's pull you off Dexcom. Let's check in 6 months and see what your A1C did. Like, is that going to continue to instill those behavioral changes, or are you going to slip back into old habits? You know, so it'll be very interesting. So we're really, really excited to be involved with it.
Can some of those people tie into what Bill talked about earlier?
With the,
Well, whatever that was that you're trying to do to reach other people.
Oh, yeah, for sure.
Like-
I mean, there's all kinds of possibilities of what Laura's, and we've had a couple meetings just talking about it. So at a high level, one of the CHIP is about pre-diabetes and kids. I mean, what do we do? And that was my discussion with the pediatrician this week, that I said that they're interested maybe in getting 100 kids that are not diabetic yet, but let's say their insulin levels, they're overweight. She said, if you need 100, I got 100 in my practice. I mean, she says, if you want, I probably get 1,000. And she was exaggerating a little bit, but it's such an epidemic. So I think all of those things are going to be interconnected. Now, Dexcom is a commercial business, and they obviously have a reason. They're giving this away because they think they're going to get back something in data to say this is worthwhile. The group we're looking at are just individuals, I want to make sure about that are type 2 diabetics that are not on insulin. Because if you're on insulin, you can use it. You can already use it, and Medicaid has approved it in Ohio. That's at least what Dr. Gray said. We're the only state that has done that. But as we talked about last time, I mean, the cost to an insurance company could be dramatic. With somebody's lost 30 pounds and somebody's hemoglobin A1C has dropped from 11 to normal. You've just reduced what your insurance costs by thousands of dollars a year on an average. And so I think the data coming out of this is going to be exciting for everyone. This is win-win-win. And then the other part is the behavioral, or how do people feel about themselves? I got to believe somebody lost 30 pounds and that they're just going to be a better employee. They're going to show up to work more. I mean, whatever society wants to look about. So I think it's just really exciting.
well, and that specific patient too, what's so interesting about her also is she got started on medication. So she got started on Mounjaro, which is a very expensive medication, but she is very much so, I'm putting $700 every single month into this medication. I will not go off of it. I will keep paying it because of how good I feel. Like, and that's phenomenal, you know? So she's you know, taking her funds and saying, this is worth it. I'm worth it. I'm going to spend this much money on this medication because of how great I've been doing. So I think that's amazing as well. Cause I mean, she goes into the clinic and you say, oh, I want you to start you on the $700 medicine. Whew. I don't know about this, you know, but when you're seeing the real time data, that's remarkable.
This study
So
is
it's very,
so
yeah.
unique. I mean, the meetings we had with their their kind of research team, it was really great. So many variations. They can look at the data, and it's never been done at the community level. I think that's what's unique about it. There's no control. We're just putting those Dexcoms on people and let them go, you know, on their lives. So it's never been done. Most of the studies, most of the research is done in a controlled environment. That's what you do. That's a diet you have to be, and so on and so forth. But this is unique, and it's never been done on the community level. I think that's the value of it. I think that goes very well with our mission of, you know, being a research facility and a data hub for not only Hancock County, but it looks like for the whole country. Dr. Grace is going to Germany next week or the week after to present on that project as well to the Diabetic Association. And this is really exciting. All the data we're collecting. If you look at the variation with A1C, the blue line is the 3 months. Is it correct?
No, blue line is initial.
yeah.
So that's the initial A1C when a person came in. The orange line is the 3 month, and then the green line, which, you know, are kind of here and there, is the 6 month follow-up. So the 6 month follow-up, we've only had 28 clients come in there yet. So that's why you don't see the graphic all the way across. But, you know, we've had like
We love the
150
greens
some,
on there. I mean, look at that. I mean,
Yeah.
just in print, right?
You know, 5.4, 5.3, 5.6. Those are normal A1Cs.
Do the 3 months versus the 6 months, do the 3 month people think they're a lot better?
Oh, yeah. Yep.
And
A lot better. Everybody says this is game changing. This is life changing. I look at this all the time.
so that means they won't do the 6 month.
I think everybody's committed. Everybody's really committed to this. A lot of patients have told me, I don't know how I did this, managed this without this product. And they can't imagine their lives without it.
Those wins they're seeing every 3 months here by coming back here and doing the A1C, talking to Laura and her team. I think it's kind of more incentive and more engaged. Okay, I
Yeah.
can do some of my health. I'm empowered by that
Yeah.
machine, and it's telling me exactly what's going on. And some I want to share with the board. Late last year, I became a little sweeter, so I was diagnosed with diabetes as well. And Dr. Grace put me on one of those as well. And I'm doing great with them. It's like magic. You know, you just really look at what you're eating, what you're doing. If you eat dinner, take a walk, you'll see right there how exercise is helping you. So I think this is going to be great for changing behavior. And that meeting with the researchers from Dexcom earlier in the week, I did say, I hope from public health standpoint, we hope you do something about smoking, because we spent 50 years trying to convince people this is going to shave years off your life, but nobody believed it at the time. And so seeing it in real life is really, really powerful from public health standpoint and changing behavior to make the right choices. So good work.
Yeah.
Question, in your earlier statistics, I noticed that you made 20 visits to the city mission. Is that because they're asking for it? Is that, I'm just trying to understand whether there's other places that are getting neglected.
So the reason why we chose City Mission to prioritize is, one, it sits within that 9.01 tract.
Okay.
So which is a really at-risk population. So I wanted to capture those clients, and also just hearing from the community, like what places a lot of clients are at that need a lot of help. City Mission was everybody's report to me, everybody's report. So, you know, going forward, I'm gonna, you know, Hope House, like that residential women and children's
Sure.
center. We're going there once a month. I'm gonna reach out to Focus has a lot of different group houses. I'm gonna start going out to those places as well, because it just seems like to me, anecdotally, I'm hearing from all these different organizations, you need to help City Mission, you need to help this person, you need to help that person. So like, I'm kind of just going where people are kind of telling me and seeing what's going on. Like I anticipated to go out to Hope House more often, but really they didn't need me. So that's why we're only doing it once a week or once a month. But City Mission, it's like, it's a revolving door. Those clients can come in, stay a couple days, or they can stay a couple of months. So, we're really seeing a lot of new patients there every single time we go out. And honestly, like if we, don't need to go different places, if we, kind of look through this CHIP meeting that we don't need to go different places, but once a month or whatever, I'd like to go out to City Mission more often. Just because I feel like the need's there. I was just talking to Dr. Kos of some of these patients that just fall through the cracks. Like there was a patient who just got discharged from the hospital on Tuesday for diverticulosis. He had a drain in his belly and he was supposed to take all these medications, including 2 antibiotics. Well, he got back to the City Mission. He looked at everything and he said, I'm not taking any of this stuff. It's got to interact. So he didn't take any of his meds. But also a month before that, he was hospitalized because he had a heart attack. He was put on all sorts of cardiac meds. So not only did he stop all of those GI meds, he stopped all of his cardiac meds. And he was just in that situation, that hole of like, there was no home health to help him. He didn't meet criteria for home health. There was no lined up services. So, going back to what Dr. Kos was talking about with care navigation or whatever we
Well,
want
it
to call
doesn't
it.
sound like he had a home.
He doesn't have a home, yeah. But he also, home health can go out to different like homeless shelters, but you have to meet criteria. He's not homebound. He can go walk around, he can go here, he can go there. So he's really not homebound. So no nursing service could go out. Doesn't matter if it's Blanchard Valley, any nursing service couldn't go out to see him. He doesn't meet criteria from an age standpoint to get different like kind of elder kind of care and things. So there's these big gaps that, not necessarily me as a nurse practitioner, do I need to take care of them, but if we don't take care of those needs through care navigation or whatever we want to call it, these patients are going to continue to go back to the hospital, continue to get different, comorbidities, hospitalizations, he ends up having a perforated bowel, has a huge hospitalization with a huge recovery or heart attack through all of this, those costs just go up and up and up, not to mention what it does to him. So like he really felt empowered when I said, you gotta go, you gotta take these meds, he'd been off antibiotics for 2 days. So like in all of his cardiac meds. So it's just a lot of education, but yeah, I could see myself going out there more often and I find it enjoyable. I like meeting those patients, getting in and really helping because they really
Right,
say
you're
you're making
reaching
a difference.
People that need to be reached.
Yeah. Yep. Yeah. So that's my goal, reaching the people that need to be reached.
Any questions for Laura? Thank you, Laura. Good work.
Thank you. Sorry, I guess chatting.
You're doing.
Well, I think the big thing, it's just for all of this, is the collaboration. It's, BJ, because, we don't want to see him back. Now I'm speaking to the hospital. We don't want him back in the emergency room. I mean, there's all kinds of things and we got to start all over. And so
Chad, you're next.
I will see you at 10 o'clock.
Sounds good. Thank you.
Thanks.
So obviously, we don't have anything to update on accreditation, but we're kind of starting that back up here pretty soon, just because our annual report's gonna be due like it normally is in June. We'll be working towards getting that up and going and start that process since we're now starting year 3. This is usually about the time we start looking at the reaccreditation process. We don't necessarily apply, but we start putting our documents and start getting all that going again. So we'll be working through that. So I'll be probably giving you an update maybe next month on where we are with that. As I mentioned, probably either November or December's meeting, I knew we were most likely going to hit the number I was glad to see with the number of naloxone naloxone kits distributed to the public. Obviously, when we started the program, we only did 283, but we did over 3,500 in 2022. Which was, again, an amazing thing. Obviously, the outreach that Jamie and Sharona and Gary are doing within the program, as well as within the now SafeWorks, formerly known as the BDIP program. We're distributing many more of those. And I'm also glad to see, too, with, again, I think direct correlation from the Safe Works program that we have here at the health department. We've continued to stay below that 100 century mark of new hepatitis C cases for the last 3 years. So I'm very pleased with that. That we're able to do that. And that's, again, one of the goals of the program, the bloodborne diseases being kept low. Gary, he and I we've been working for the last probably week and a half, 2 weeks on a grant. So that's why there's no narrative. He just gave statistics. We were focused on, because today's our deadline to get this grant in, that is through NASTADS, the National Alliance for, I remember as soon as I just said it, I forgot it, but basically it's a national grant, and it's focused primarily on strengthening our syringe service program. And what we're planning on doing is we're actually planning on adding a second location here in Findlay, and it's going to be most likely in that same census tract of 9.01 at the down on Front Street, which is where Spectrum is currently located. We're going to be partnering with them. They're the organization that serves the LGBTQ plus population. And we also know through our conversations with them that the population they serve is at higher risk for substance use or abuse. So that's why we thought they would be a good partner. And we're also going to be working with Equitas, who also provides our HIV and syphilis testing here at the health department during the Safe Works time slot on Wednesdays. We've already communicated with the city because it's a requirement anytime we set up a location or look to consider another location, we have to communicate with the municipality that location will be within. So we've done that.
And just on that same grant that they're applying for, Chad and Gary put together a letter of support that they would like Dr. Coase, the board president, and myself to sign on it so they can submit part of their report too. This is a basic, support of the board to that program and for the expansion and support for them to go after that money. So I'm going to ask you to sign on behalf of Brian afterwards, please. So because it's due at the end of the day today. So
yeah. So yeah, and the idea behind it, basically the overview is we're planning on hiring, while contracting with Equitas, to hire a peer navigator, a peer support, very similar to what Jamie and Sharona do, but also a navigator, which is one of the things that we've identified that we need to be able to direct people for referrals to services, things of that nature. But we'll also be able to pay for some of Jamie's time to help coordinate between our fixed location here and essentially our satellite location at Spectrum, and some other additional costs. So it's about $150,000 grant that we're going after. It'll be a 1 year, but hopefully a continuation up to 5 years. So that's all based on funding. The health education side, Jess has been pretty busy, primarily with, as Kareem mentioned, the CPR courses and AED courses. Those are being offered in the community, but again, she's also starting to get back into the schools doing the nutrition. That's been keeping her busy. Dr. Coase already talked about the car seat program that we're working with Blanchard Valley. Obviously, we're still continuing to work through best practices on that. We know it's a valuable service, but just trying to streamline that a little bit and where we can get in prior to the babies being delivered. Looking at maybe working with the OB offices that are overseen by the hospital, and then that way we can get in ahead of time and start that conversation earlier as opposed to when the baby's born. We can do some of those checks ahead of time in education. As far as epidemiology, I know Hannah's been busy. You're going to be doing a radiation tabletop exercise coming up at the end of this month. We have to do certain functional or tabletop exercises per the grant. So she's working on getting that set up. We had a meeting earlier this month, just as a planning meeting. Obviously, you can see we're still doing the COVID thing, communicating that out to contacts. We are considering possibly, because a lot of health departments are not necessarily notifying cases anymore, but it's something we've talked about because of the cost, sending those letters out and the value of the letters anymore. Initially, there had been value, but not so much anymore. People, pretty much know what to do. Communications. Cheryl's obviously been very busy. She's continuing to put postings out on, as you can see, a variety of topics. Obviously, she's also been involved too with Hancock Leadership, and that's an annual year-long process that they work with other community partners to get networking opportunity, but they also work on projects to better the community. is pretty much everything I have, unless there's any specific questions.
Any questions?
Okay.
Thank you, Chad. Good work. Shannon, you're next.
Oh, those two reports. So you guys met Deanna this morning. We are really excited to have her. It's been a good start to the week, and I think Kareem and I were both really happy that it was a pretty quick turnover, and Mindy from the state will be doing training with her next week. So it'll be kind of interesting training her, because a lot of what part of that training is where you document and where you do things at. So it's next month when we switch over to ECW from HDIS, but I've warned her and she's got a real open mind, so I think it'll be a good thing, but I'm glad she can be here for that onboarding as well. School nursing, there's really nothing new there. Communicable diseases, pretty status quo. I mean, I believe, I want to say in November, we had around 12 hospitalized influenza, I say around that. So as to be expected, December was 37 following Thanksgiving and Christmas. So thankfully, like Kareem mentioned earlier, we're on the downswing of that.
We have the Super Bowl coming up yet.
Uh-oh.
Maybe it'll be nice out that day. Who knows with Ohio weather. Clinics are, this is kind of more of a slower time for us. So the girls have been working on the Get Vaccinated grant. This is one of our times where we reach out to the school nurses and all the county and city schools to provide them education and information targeting, those school related vaccines so that we can start to get education information out for the spring. I know Laura had to go, but that's one of the things we're going to work on, is really getting out to those schools maybe the end of the school year. If not the end of the school year, definitely in the beginning of the school year, to offer some mobile clinics for those back to school vaccines. I think I did put in there kind of what percentage our overall vaccines have dropped over that was just an average of the last 4 years of what we've seen. I believe it's pretty on par for what they're seeing nationally and statewide. I had trouble finding like an up-to-date data on that. Like Kareem said, it's always a couple years behind, and with COVID being a couple years behind, it really is hard to get something realistic. But as I've been watching month to month, I've started to see us close that gap a little bit more and a little bit more, but we're seeing a lot more adults come in for vaccines now, which, we want to get those kids in here, but it is kind of balancing as far as the work and the revenue, but we do want to get those kids back in. I think a lot of that adult vaccine is because we had those COVID clinics and we got so much good feedback that they realize what the health department does and they want to come back to us for more. So that's encouraging. One thing I forgot to mention earlier is, nope, you're good. On the call, was it last week? I believe they did finally close out the hepatitis A outbreak in Ohio. So it's kind of been in the back burner, but gosh, that's been going on since 2018.
Yes, that's going on for a few years.
So I'm glad that's out. There was something else I thought of, but I don't remember. And then as far as COVID clinics, we are still seeing about 20 to 30 people come every Friday. So I mean, they're steady for now. Otherwise, I really don't have a lot of new information to report on unless you guys have questions.
What are you seeing in the COVID clinics? Is this long COVID type patients or?
Just for the vaccines.
Oh, just for the vaccine?
Yep.
Okay.
Yep, so, I would say mainly we're still seeing like the people coming back for their boosters. We're getting like maybe 1 or 2 here and there with starting the series, so. This is good, every little one helps, but most of them are being boosted. And then working with Laura with the STI clinic, Jane and myself will start with the training to be trained and help the mobile health staff out with that STI clinic. And then we'll kind of just see as it grows, how much more nurses we need to get involved, but I think it's definitely needed here in town for sure. So.
That's great.
Very good work.
All right.
Any questions for Shannon? All right, let's hear from our ever-growing program here.
Yes, for sure. Good morning, everybody. We closed out the books. This shows our revenue and our visits through the end of last year. So revenue looks wonderful. Visits, you'll notice it seems like it's down. However, our information from 2020 and 2021 were inflated because we were doing things like drop offs, visits, and seeing families more frequent. So just a few program updates. We are serving 127 families total between Hancock and Wood County, and our Wood County numbers are growing. So we now have 7 out of our 10 slots filled in Wood County, which is encouraging. We have 15 families on a wait list here for services in Hancock County, and I really think that's where a case manager or a care manager could come into play, where they could reach out to those families that are awaiting services and they could help them get active on Medicaid or get OBGYN services started. Right now, we do prioritize those families, and our goal is to get them on the program before they deliver their baby. We did have a group connection last evening. We're partnering with the OSU Extension Office, and it was a great turnout. So we had 31 families that originally RSVP'd. Only 13 made it. However, we did have a January thunderstorm at the same exact time that our group was planned for. So we overall were very pleased with that. And she is coming in and she's talking to them about cooking with their WIC benefits and also making healthful food frugally. So that will really come into play with food stamps cutting within the next couple months. I'm sure you've all read that the pandemic benefits are ending. So they'll see a huge slash in the benefits that they receive monthly. So she did a chicken tortilla soup, and we have meals planned with her for February and for March. And then just to round out the report, we have a couple grant opportunities that are moving along. We had a site visit from Handbags That Help yesterday. That went very well, and I definitely feel like the need for transportation, especially for the program clients and community, resonated with that group well by the time that they left. So the next steps in that process will be the group that was assigned to come do our site visit will then report back to the bigger group, and they will collectively decide if we make it onto the ballot for a return presentation and then for those members to vote on that initiative. And that is to provide hats, transportation to and from our groups. And then a couple grants on the horizon I will be submitting for Hancock Reads. And I really, really want to focus on getting some bilingual books for the influx of non-English speaking families that we have. I just did a calculation last week. 10% of our families do not speak English. So
Wow.
that's huge. And we really want to get some resources for them. And it just continues to grow. It continues to grow. It's mostly Spanish, but I really want to be able to provide those kiddos, especially with some books. And thinking families and parents that don't speak English, sometimes those books, even though they're for babies and toddlers, the parents can then learn as well. So I'm hoping to partner with the library to get some funding for that. And then I will be applying for the Ohio Children's Trust Fund grant. We were recipients of that. It was a 2-year grant. They're changing it to a 4-year opportunity, and that is focused on parental education, preventing child abuse, and strengthening and making homes safer for kiddos. Yes.
I know the library has that literacy program.
Yes, that's who I'm partnering with. It's called Read for Life. Teaches them English. So yes, Christy is involved in that. I'm meeting with her next week, and I hope we can get a good initiative started.
Are we seeing any influx of immigrants into our area? And
Yes.
and how do we help them, and how do they get integrated?
Yes, that is a huge concern for our community. Right now, we have 15 families that do not speak English and are dealing with immigration issues. So I definitely think that's where a case manager could be helpful. We are working with them the best that we can. It seems for whatever reason, they're reaching out and getting connected with our program first. So that was definitely a topic that we discussed with the OBGYN group that was here last week, the hospital, how we can connect these patients to services. And also we've discussed about having Laura go out there and get them some care because they don't have insurance. They don't qualify for benefits because they're not citizens, but yet they're still here in our community. And we still need to help take care of them. A lot of
They have
times
housing?
they're living in hotels.
And motels, actually. And that was a topic I brought up in our delegation meeting earlier this week, and looks like nobody wanted to talk about that issue until I brought it up. but needed to be discussed at the community level. And that's what I told everybody at that meeting, which I told them, you know what, now they are needing our services. We're struggling with translation and everything else. But eventually it's gonna trickle down to all of the services we have in the community. The mayor is aware of that. I think she's putting together a coalition to kind of tackle that issue. They are living in Motel 6 and 7 or 8. There's a couple of them here. Motel 8. So, but
They're
anyhow,
on Broad Avenue.
it's not the a good living conditions. It looks like there was a lawyer advocate on that group too that mentioned probably that group of migrant workers came in the summer to work in the fields. When the season ended, they stayed here because factories like the cookies factories and Macomb and other factories offered them jobs. With nowhere to live, they cannot afford housing. I think they're living in the motel, and actually the cookie factory from Macomb will provide transportation for the people who are working in their factory every day to go work there. Problem is the families and the children who are left here, they're gonna need services and social services. The tricky part for us is some of them are not legally here. We're not immigration specialists. We cannot ask for papers. uh, but we're gonna have to figure some on the community level more than just us involved in that. We're doing our best to serve him. We're looking into translation services now because it's needed. It's beyond, Spanish now. It's other languages like Portuguese and other languages we're seeing.
Haitian Creole.
Yes. So,
Significant.
probably, Craig in a little bit will talk about what he's looking into, but that's something we need. After they started showing up and, as clientele of Alexa's team, they start showing up with some of our vaccination clinics as well. Um, the bottom line from public health perspective, I think they need to be taken care of because they're here. They're gonna affect the whole community. They're gonna be working at your grocery stores. They're gonna be working at the fast food. They're gonna be working at the factories. Putting our food together.
Well, kids will be in the schools.
In the
if we don't
schools.
get them vaccinated.
So this is
A lot of them are pregnant, so
Yeah.
I mean, their children will be residents.
So it's a
That's my
huge-
biggest concern there. Older mothers, 40 plus, no prenatal care, and maybe this is their 6th or 7th pregnancy. So it just flows over into the community and there's implications.
There's a safety and security concern as well that was brought up at that meeting I was into. Those motels are known hubs for drug trafficking. They're known hubs for human trafficking. I mean, this is not a good situation. I think
They're easy targets.
They're so vulnerable.
so. I did elevate that to kind of get priorities on the community level to deal with. This is beyond what we can do as a Board of Health. It's more of a community needs to come together and kind of figure out something.
What other agencies can contribute?
There was a lot of agencies around the table. Like I said, the city was there. The Community Foundation, the United Way, Adams Board on that committee. Legal Aid was at that committee. Melissa was there, and she did a lot of insight on the legality of what's going on. So maybe as a first step or action items that came out of that meeting that we need to kind of outreach to the cookie factory and make sure they're doing the right thing is by hiring people who are here legally or something like that. This is again not our specialty, but it's affecting us first, and it's going to trickle down to all the services we have.
Do we know how many people are involved? You said 18.
We
Families.
have 15 families,
Or
and I know I've been in communication with Christy, who is the leader of the program that we're referring to that teaches them English, and I know she has a group of just 20 Guatemalan families that she's meeting with every other week through a church. So that's another one
According
of our
to that group,
thoughts.
there's a lot
They're
more.
church
Than
sponsored.
the 15 families we're seeing, there's a whole lot more.
Yeah, I didn't have a percentage, but the girls said like during busy season, we were probably seeing about at least 5 clients a week. And like right now, we probably see maybe 1 or 2, but it's time consuming. when
It's
you're trying
intensive.
to, You know, go back and interpret an entire vaccine record and then explain to them what their options are and get their consent without having, which I'll let Craig talk about it. He's probably like, can I get my report done at this point? But, you know,
I'm sure the
It's
hospitals will be
translate.
affected as well.
I'm sure in
I'm
the
sure.
ER, you're probably seeing, I would think, but I don't know.
There's also such a need in this community for entry-level positions. And it just makes me wonder how we could, participate and,
Looks
and
like
help.
they're here because there's work, but how can we kind of?
But you have to hire them through a legal
That's
process, and
correct.
how do you do
Correct.
that?
Exactly, and there's so many roadblocks. I
Chamber of
mean, we
Commerce
can't get
was
them
there.
housing, we can't get them into schools because they don't have the documentation, and trying to get those documents from Haiti or from Cuba are terrible.
Are there
for
any,
BCMH, we have a client, but they don't have a social security number, so they didn't have the Medicaid denial, so thankfully BCMH is a little bit more open to, okay, send me what we can and we'll work with it, but.
Yeah.
Like you said, so many roadblocks.
Is there a need for a translator somewhere in this
Oh, yeah.
mix and who
That-
funds that and?
We gotta look into, we're looking at what the hospital is using now, which is FaceTime kind of translation. Because you'll have more options and languages. This is gonna come with a cost, and I'm sure, I did task Craig with looking into that, and probably he'll report on it a little bit to you. But that's the best way to do medical, translation is face to face, and especially we're gonna need the face to face because of the sign language as well, that might be needed at some point.
I know
You're right,
trials.
It's gonna trickle over though, because then we're gonna send them to JFS to
Yep.
get these documents. If they don't have someone to translate, they just.
Well, Nancy, you brought up a good point because I know the one family, I've done my best to try and spread them out among home visitors. That way one person isn't taking on all these intensive cases. But you bring up a great point. I know the family that I'm working with, they are having court hearings because they're driving without a driver's license. Well, how do you get a driver's license? I mean, it just overflows into all these other community agencies.
I know that they're using Zoom translators in trials now.
Okay.
Yeah,
I was talking to some other lawyers that,
similar to that, we want some that's HIPAA compliant. I think we looked at what the hospital's using. It's a little bit pricey, but I think we're gonna have to afford this.
is there any way to do that, through a community initiative so that wherever they are, rather than just at the health department, they would have access to that translation? And the hospital has to do that because we can't risk a relative interpreting what the surgeon is saying. Because if they misstate it, we would be, it would be, very problematic. So we have to use a very formal process for translation, but it's very easy access. I just wonder if the health department's gonna get something, would there be any way to go in with the city or the county or other areas so
a
that
great
everybody
idea.
would have access?
We help them place these phone calls, and then on the agency's end, without the translator, they have no clue what these people are
Yeah.
saying.
Yeah,
I think
Didn't you mention like, I know maybe work with Community Foundation on
that's correct.
community kiosks, like at different locations, they'd be positioned.
That was my initial idea, is to go to the foundation and tell them, Alexa and the staff got me some numbers and say, okay, you know what, there's a need now. And the foundation was at that meeting of the delegation, and they heard, that everybody is kind of started to experience some of that, but nobody want to talk about it. So there will be opportunity to do kiosk and like basic social services, the city services, the county, just for those individuals to be able to communicate via that translation service.
what about English, classes?
Yeah.
The library, they are,
They're doing that?
Yes.
the library was at that meeting as well. The Chamber of Commerce was at that meeting. So it's the way I described it to my leadership team in our meeting this week. I said, you know what, this is kind of the perfect storm here, and it's gonna hit any minute, and we're gonna have to be ready.
And my concern is this growing season is going to be upon
That's
us
correct.
again. There'll be more.
Well, and my concern is, are there employers anywhere in our county undercutting other people that need a job? And, are they, is this attracting more of the people that can't speak
Right.
well for themselves to live in a motel room?
Yes. Yeah, and I mean, there's social issues too. I
All
mean, the
kind of legal
hotel's charging
social
them
issues.
$400 a week to live there too. So whether it's right or wrong,
Who's paying that?
I think
the employer,
The
sometimes
employer
they have
sometimes.
family, sometimes there's churches that are sponsoring them.
well, that shortage after COVID of workers created some of that too.
It's a deep problem.
It's, yeah, and I hope that you guys will never hear about it in future meetings, but my suspicion is that we will be discussing that moving forward.
One more thing, I know we're running short on time, but I do want to bring up that I attended the United Way meeting in regards to the food stamp coverage that's going to be ending, and we are working on some initiatives here. One thing that I'm really concerned about is formula. I know a lot of the families are using their SNAP benefits now because WIC is a supplementary. So it doesn't provide a baby's entire month of formula. It's just meant to provide a percentage. And I know a lot of the families right now are using their SNAP, their food stamp cards to buy the rest of that formula. Formula is experiencing shortages again. It's still hard to find. And I'm worried about these babies if food stamps, when they do get cut. But that's a concern we're working on in the community.
Very good.
Where is the line drawn between, that you go north as Hardin County is south?
For Wood County?
Yeah.
Wood County, we serve North Baltimore, Fostoria, Bairdstown, and Bloomdale. So just that southern
That's where
tip.
the line is.
Yes.
Oh, okay.
Yep.
Very good. Thank you, Lindsay. Lindsay,
Great. PH numbers, they're status quo. If you look at the inspection trend line, you can see that we're right on trend with our last couple years. We're actually gonna be able to get all our food inspections completed on time this year, so we're excited about that. I know in my report I had put that I had some interviews, hopefully scheduled. 2 people didn't return my calls and the one that I scheduled did not show. So I'm still searching for, that sanitarium position. We also had, one outstanding body art facility. They are now in compliance, so all of the body art facilities have a current license for the year. The next thing I'll kind of get into, which is kind of going off of some of the work that we're gonna be doing with the chip in that. We do the tobacco compliance inspections. That's what Ryan takes an operative out and tries to make sales. The operatives are anywhere from 16 to 20 years of age. This past year in 2022 is probably the worst that I've experienced, and with Corinne being on board, it's quite alarming. We actually had one location that sold twice in 2022 to someone. That's the first time that I've ever experienced that. Usually after that first time, they can at least make it 3 years. Because what we do is we tell them when they come in on that first hearing, it's an educational conversation, and then Corinne will suspend the fine. But if they sell again within a 2-year time frame, then they get hit with the fine. We ended up issuing 6 fines to 6 different locations because they sold within that 2-year time frame. Again, that's something that we haven't experienced in the past.
How do you catch them selling?
Ryan goes in with an underage operative, so
they try to buy cigarettes.
they try to buy any tobacco product.
Tobacco
So
Oh, it's like espionage.
We call them compliance checks.
the common themes that we're hearing when we have these hearings or when Ryan follows up with them are simply they just didn't ask for an ID. They thought that the person was a regular. Or they were just too busy trying to get customers through the line, so they didn't pay attention. And I'm gonna say probably 99% of the people that we talk to, they have resources available to prevent that sale.
They have scanners, like on the register. They won't let you make the sale unless you scan the ID. A lot of cashiers, because this is a very stressful situation for a cashier in a convenience store. People want to get in and out quick. So they don't want to, they don't want to upset the customer. That's why they don't go to Kroger's to get their cigarettes. They go to the convenience store or gas station. So they want to move people quick. And in the, for that sake, I think they're foregoing asking for IDs and selling to minors. So this earlier this week alone, we had 5 hearings for those things, and all of them were repeat offenders. I did fine them all $250 a piece. And I told them, you know what, this is not about the money. It's about, we want some incentive for you to watch what your cashiers are doing more, and for them to realize that this is a serious matter, that the Board of Health don't want, underage sale here. That's why our 2019-01 resolution, that's what it talks about. So I think everybody's pretty understanding, but we're hoping that we don't have to, we never had to hit them in the pocket to be able to kind of get compliance, but we're hoping that this will get the message a little better, especially if they are repeat offenders. That operation was right in December. It was around the holidays, and all the kids that we had going and trying to buy cigarettes under our watch, they were buying, cigars and cigarillos and the flavored tobacco things and all those kinds. So this is not good. So hopefully we're getting the message through this, but we have to work a lot harder on with the operators, and we try our best to do that as well.
Do you find that the compliance checks are occurring at convenience stores versus supermarkets?
We do them at every
All.
location. So
We
we
do all
license
locations.
132 establishments. So
Twice a year.
Yep. So everybody gets at least 2 inspections.
But I mean, the violation.
Oh, no, they're happening.
We did see one at a Meyer store
Yeah,
a few
we've had a
months
few
back.
Kroger, or a few Speedways.
Yep.
So it's not standard for a system that they have to scan their ID?
It's the
They-
store's policy.
they-
A lot
they-
of them have it, but
They
they.
can bypass it. The cashier can say, okay, born in, the 60s.
We've had some people say, oh, I just entered my own birth date and
Yeah.
done.
I'm not to that age yet.
You are a device to defend.
Yeah.
You want to be an undercover since? All right. Very
Oh,
good.
One other quick thing,
Yes.
we did get our EPA solid waste approval letter for doing the solid waste program, so that's good news. And I hit the button yesterday for our mosquito grant. I applied for a little over $24,000. I also reached out to the vector control technician that we had last summer, and she actually found a love for mosquitoes that she didn't know that she had. And she is excited, wants to come back this summer, and she's going to incorporate a mosquito project into her senior year project. So excited about that.
Win-win. Thank you.
Yes.
Very good. Correct.
All right. Yeah, just to touch on the language issues, I was tasked with kind of finding a solution, especially with the nursing staff seeing a lot more clients. That is a big risk of making sure they're properly informed when they come in for their vaccines and things like that. So we did reach out to the hospital, looked at what they're currently using, because it did sound like a good system. Basically, I think it's an application on whether it's an iPad or other device where you can tap into a translator to help translate. The biggest barrier to that's going to be is the cost, specifically for the application. It's about $2. What I got back from the company was about $2 per minute for translation services. And there also is like a yearly cost of $1,000 that you have to meet, or they charge you an extra fee just to kind of keep a contract with them. So kind of how we were talking today about more of a community type translation, it could be an option with this company. And I might just reach out to them to see if there's any way we could apply for maybe a prepaid service where you pay for the minutes up front, a large block. I know a lot of times those larger blocks, maybe we can get a discounted rate. And that way more of our community partners maybe it's something we want to reach out to the community foundation about to see if we can just get like a pre-play block. So I will investigate with the company. I know the phone translation's a little cheaper. If you have somebody on the phone and need to be translated, it's, I think, around like 75 cents a minute. So it's a little cheaper than the $2 a minute that the application, but the phone one's obviously a little harder to use on a in-person basis. So, so yeah, we'll be doing a little more investigation to see kind of what our options are going forward on that. So, just to give you guys an update on our, new EMR ECW. I've been working with, our current vendor HDAS to export the data into ECW. Good news is I got notification this morning that they finally completed that process, and we have a meeting scheduled for next week to do a verification for the data. So we'll look at, I think, around 15 patients and kind of a spot check to make sure all the data from our current system transferred over into the new system. So once that's completed, then it's gonna kind of be in hyperdrive on getting ECW, because that's kind of the first thing they need to do to get start setting up everything, was to get some of the data in our system. So so we will be very busy, and Shannon and Dan Klein, our register, have been very busy helping out with this project. So I think our go live date is, I think, the week after President's Day next month. So it's about a month away. So we're looking forward to it, but it's going to be a lot of work getting things ready. And I'm sure there's going to be a lot of pain points in there, but we'll get through them.
6 months.
Yeah, it'll be well worth it in the end. So, and then part of that, I'm just working as, once we move off our current EMR system, I'm going to be upgrading a lot of the nurses' computers. It'll just make things easier. They're due for replacement, but also will make things a lot easier once we're on the new system to upgrade their computers. Some of our server changes on the back end, I'm trying to complete now. But once we move off the old EMR, that'll free up some resources that I can dedicate to like backups and things like that to make our internal environment a little more secure. So.
Questions for Craig?
Craig,
Yep.
you mentioned about this translation that we have talked a lot about today. And is any of your information useful in trying to get a grant?
Possibly. I mean, I don't know what, we would have to find a grant that would be kind of applicable to that area and would cover that, but.
Well, I was just thinking about the community foundation, because this
Yep.
sounds like pretty much a community issue.
Yep. Yeah, that's definitely something I'm gonna be looking into to, obviously be able to present on a community-wide, not community-wide level, since there is obviously a need for that now, so. Yep.
Very good. Good work. Thank you, Craig. All right. I don't have a lot to add to all what you heard this morning from the different programs. I just want to say that usually the first quarter in public health, it's kind of busy for administratively. We have reports to the state to submit in the first quarter. The annual financial report we have to submit to the state. A lot of other reporting. We're working on the annual report with Cheryl and the rest of the team there. We're working on setting up the DAC meeting. It's going to be the first Monday of March, which we'll talk about in our next meeting in more details. I'm working with the team on health equity report, and I'm working on the finalizing the CHIP. So it's been a busy January here, and I'm expecting that we'll be really busy through March here to just kind of finish up all the paperwork and all the administrative stuff that are connected to administrating the health district. But we're on track. I think we're doing pretty good. Legislatively, there was a lame duck session. Just a quick summary. There was a tobacco preemption bill, which House Bill 513. that went through Congress really quick during the lame duck session. That's to kind of preempt local government from putting resolutions and laws for, for smoking or restricting tobacco sale to the like what happened in Columbus, where they restricted all flavored tobacco sale within city limit. So, so the House tried to preempt that. It passed and everything, but the governor vetoed that bill. So I think our resolution 2019-01 is safe. I don't think we can still go undercover and do those compliance. But that was vetoed by the governor, which is good. Another bill of interest to you would be House Bill 507. That's the food survey. How they do food surveys, how the state will do food surveys. They used to, for the longest time, and I was an auditor with the state for that program as well. We'll used to go with the inspector into a facility. We'll pick 2 or 3 facilities, and we'll go with the inspector and spend days trying to see if the inspector is up to par or up to standard of what they need to look at in a facility. I think a lot of pressure from the Restaurant Association, a lot of pressure from the Ohio Health Inspector Association. They did do away with that part. So the law is not for ODH or Ohio Department of Agriculture to come in and evaluate inspectors in the field. It's going to be a test now, an exam going forward. I think it's a lot better. It's a lot more beneficial because having the auditor from the state come in and spending a day with the inspector should be more about learning the inspector asking questions, all being on the same page across the state, standard type of thing, not to punish and kind of, it was really burdensome on the operators. There was inspections where they will go in and spend 8 hours, then 8 hours the next morning, come back with 20 pages report. There was no value to anybody. So I think this is a good thing, and it did pass the House and signed by the governor as well. So it became law. It will become law in 90 days. House Bill 463 and Senate Bill 324, the same bill. That called for the DAC to be dissolved and Board of Health to be restructured. That didn't go anywhere in the lame duck, and I think it's dead for now. Other bills of interest, House Bill 254, that talks about domestic violence review committees. House Bill 45 talks about lead abatement. And I think of interest to us would be, or to everybody, it's Senate Bill 288, where fentanyl test strips became legal. They were illegal before, and that's why we didn't include them in any of our outreach, but now they're legal. And then House Bill 558 that do with Narcan liability and the Good Samaritan law that will protect people who are given Narcan in the case of an overdose from any liability associated with the risks. Basically, there's no risk, but this is like a good thing that passed as well to make it more widely available and people will feel more comfortable using it. All right. I think that's from the legislative end, and I've been into multiple meetings with Dexcom, Dr. Grace on that study. I think we've talked a lot about it, but I want the board to appreciate the value of that study. This is going to be really big, and once this is all said and done, already talking to Dr. Polinsky from the behavioral side last week and talking to the researchers with Dexcom and the local doctors here, Dr. Coates and Dr. Grace. I think this is, it's going to be big, and our public health associated with it. I think it's going to be big for public health here in Hancock County as well. Even we heard it from Dr. Polinsky, said, well, it's never been done before. It looks, he always, he was addressing Dr. Grace on that call. He said, it looks like you have a great public health infrastructure to be able to do such a study. Any other places would be very hard. So this is really positive, really encouraging, and kudos to all the staff who really make it. That's my report in a nutshell. I know it was quick, but do you guys have any particular question about any of the things that you heard today? We can address it.
Just really good work.
Thank you. Very good. Well, hopefully next,
How
this,
was your letter of last month received?
it was received well. The mayor did reply to that letter and she did express that, that most of the recommendations of the letter, they're trying to enact in the city, with city departments. There's a follow-up meeting that the commissioners called for. That's next week. It's like a roundtable discussion of all the leaders of agencies and elected officials to kind of come together and say, okay, you know what, we're having that issue. The recommendations that we heard in the letter, how can we make it happen? So there's movement on that. I think just talking about that issue is progress. But to see instant feedback, I don't think we got instant feedback, with the exception of the mayor.
No, that's, you gotta do it.
Yep. One thing next month, we're gonna bring to you some nominations for champions of public health that our leadership team is gonna put together from what they gathered from staff and their experiences with who advanced our mission in 2022. And we'll get the board to kind of pick one or two, whatever you guys choose to be the recipient of the 2022 public health champion in our community. Then we'll do the resolution in March, in the March meeting, and the actual event in April during Public Health Week. That's all I have, BJ.
Old and new business?
Personnel, we did talk about hiring Deanna. That was pretty quick turnaround, which is great. This is a very specialized program, takes a lot of training and onboarding. I think that first week, Shannon's doing a great job, and she did a great job in the transition as well, keeping up with the workload. So we don't feel any interruption. The family we're serving, they won't feel, it will be seamless, and I'm positive.
Exactly what are medical handicaps? How severe?
Oh, it ranges. Do you want to explain that a little bit?
Anything from a bleeding disorder to completely incapacitated. I mean, it can be asthma, it can be scoliosis. There's just the biggest thing that CMH does not cover is on the treatment program would be like autism or developmental delays. So let's say like Down syndrome, they may not necessarily cover Down syndrome, but a lot of those kiddos have heart conditions. So their heart condition would be covered in.
So like some of those examples, would that be a BVC sort of issue?
Blanchard Valley, yeah.
For
As
developmental,
far
yes.
as, yes.
Yeah.
Well, and the biggest thing is CMH really works as like our nurse is more of like a case manager, making sure and connecting them to those services, making sure they have a doctor that is a CMH provider. So it's kind of like a secondary insurance. But there are things within that program that we can help cover that maybe a lot of other insurances can't. So even if they have Medicaid, for example, I was working with a family this last week, Medicaid doesn't cover wipes, but this child is incontinent and that's a huge cost for them. BCMH we were able to get that service added on. All those services get added on with the supporting documents from the providers. And if they have that supporting document, then BCMH goes back and looks at it on the state level to see, is this something that we can add on and how much how much can we pay for? And they add those services on, they run it through they run their primary insurances first and then BCMH is the payer of last resort. So the diagnostic program is an initial, that doesn't, you don't have to have any financial capability. You and I could go on that. Children can, not you or I. And that area, there's more diagnoses that are more lenient because that really is an opportunity for those families to get all the testing done, which can be very expensive during that initial phase, and find out what is wrong with the child. So maybe someone who thinks their child is autistic, they might be doing genetic testing and all that kind of stuff that they can help pay for that. If it turns out it is autism, BCMH that's not a qualifying diagnosis. I don't know if that's because we just simply wouldn't be able to support that many kids in the state of Ohio.
But it sounds like the services are, you need to educate the public that you have them.
Yes. I mean, even if you look in the report, if you look back on how many providers or how many families I think we've had in the last couple of years compared to now, like we have definitely increased that amount. It's just hard in Ohio, in Finley, because we don't have a lot of pediatric specialties, and a lot of these kiddos end up seeing a specialty doctor. So we do like Kaufman Clinic there, pediatric physicians are both providers for primary. I think we've got an ENT, but we just don't have a lot of providers, but I think a lot of that goes back. It is a lot of work on their end and paperwork. We don't have a lot of pediatric specialties. Most of these kids are going to Cincinnati, Columbus, those, Cleveland.
So that position is more of an advocate for those families and try to find them resources and connect them with the right places and like secondary insurance, like you mentioned. Thank you, Shannon. All right, so another old business, we did table a Board of Health action late last year about establishing the, teaching public health department. There's no movement on that either. So it's, during the holidays, it's been really hard to kind of do meetings and stuff, but we're gonna put that on the back on high fire here to get it going as soon as we can. I think this is valuable, especially goes well with what we're doing, as far as the chip and being a research facility and everything else. There's speaking of that, I want to show you something, a nice surprise that we got yesterday from one of the Japanese student that we had here last year. She was a nursing student in Japan and she visited the United States for about 6 months. So yesterday, Professor Hiro came. They were visiting Japan during the holiday, and she did send with them 2 boxes of cookies with this little note on it. That was. I am. So that's why I want to share it with the board.
We don't know how many, unless you can read Japanese, we don't know how many
Right.
calories or
But that was,
sugar.
that was really nice and really appreciative. I did report last year, all year, about working with the Japanese counterparts on COVID issues, how they dealt with some of the COVID. And I think that was valuable partnership. So we're not only going statewide and national, we're going international.
These are low calorie.
Oh,
I just
perfect,
translated.
perfect.
You're hired.
I think the Dexcom will be able to tell how much sugar in there. But yeah, so I just want you guys to be aware. I think this is kind of good testament of the good job our staff did, kind of hosting her in here, have her show her how things work in the United States in general and in Hancock County. So she was very impressed. She's a very smart young lady. And that was nice for her to wish us good, happy new year this way. So I think that's all I have. There will be no continuing education today. I think it's getting late, a long day, but we do appreciate you being here today and happy new year.
Yeah, on behalf of the board, I think we would all say thank you for the Christmas gift and the
Oh,
calorie.
Very nice.
You are welcome. It's hard for the holidays to kind of gift something that's with no calories or low calories. But I hope you and your families enjoyed it, and we do appreciate all of us, all the support you guys given us for the last 7 years here and moving forward to infinity and beyond, right?
We have a motion to adjourn.
So move.
Second,
It's 9:39.
Second.
all in favor?